This episode of the OrthoBullets podcast will go over the topic of THA pseudotumor, or metal-on-metal reactions, from the Recon section on orthobullets.com. Let's start this episode with a quick summary. A metal-on-metal total hip arthroplasty pseudotumor, also known as aseptic lymphocyte-dominant vasculitis-associated lesion or an ALVA lesion, is a mass-forming tissue reaction caused by metal-on-metal wear. Diagnosis involves obtaining a metasubtraction MRI study in the setting of elevated serum metal ion levels, specifically cobalt and chromium. Treatment is typically revision arthroplasty for symptomatic pseudotumor with elevated metal ions. Now let's get into the episode. With respect to epidemiology, as far as incidence, 10 to 15% of patients with metal-on-metal total hip arthroplasty have a pseudotumor. 45 to 50% of revisions in patients with metal-on-metal total hip arthroplasties are due to pseudotumor or adverse local tissue reactions. As far as risk factors, the ones to know include elevated cobalt and chromium levels, female gender, and a high acetabulum inclination angle of greater than 55 degrees. Moving on to etiology, with respect to pathophysiology, as far as the mechanism, there are two different mechanisms that have been proposed for the formation of pseudotumors. That is hypersensitivity to metal ions and local high-wear debris. Note that there's a variability in distribution of metal debris, degree of necrosis, and number, type, and arrangement of inflammatory cells. Macrophages and lymphocytes are present in all cases with lymphocytes being predominant. Patients with high wear have more macrophages than those with primarily hypersensitivity to metal ions. Note that patients with extensive infiltrates of macrophages tend to have smaller lymphocytic aggregates. Moving on to presentation, as far as history, patients may complain of gradual onset of symptoms or a sudden inciting pain in the groin. As far as common symptoms, some patients may be asymptomatic, but if they are symptomatic may exhibit groin pain and or a Trendelenburg gait. On physical exam, inspection may reveal a soft tissue mass around the hip that may be present. Neurovascular exam is usually normal. And as far as provocative tests, these patients may have groin pain with flexion, internal rotation, and adduction, as well as groin pain with rising from a chair. Moving on to imaging, recommended views on radiographs include an AP pelvis, as well as an AP and lateral of the affected hip. Radiographs will show metal-on-metal total hip arthroplasty. Remember, it's necessary to rule out periprosthetic fractures as a source of pain, and imaging may show periprosthetic bony erosion, commonly seen in the calcar region. An MRI with metal artifact reduction sequence, or a MARS MRI, is indicated when there are normal radiographs in the setting of elevated metal ion levels like cobalt and chromium. As far as findings, a pseudotumor will appear like a fluid collection or solid mass in the periprosthetic soft tissues. T1 weighted images will show signal similar to bladder contents, that is transidate, while T2 weighted images will generally show hyperintensity as compared to muscle and may be heterogeneous or homogeneous. The hypointense content observed in T2 sequences may be related to the presence of necrosis or metal deposition. As for studies to obtain in the setting of a pseudotumor, serum labs should include a white blood cell count, ESR, and CRP. In addition, you should obtain metal ion levels, specifically cobalt and chromium. Know that serum metal ion concentration is highest at 12 to 24 months following the index surgery. This correlates with the initial, quote, wear-in or, quote, run-in phase of increased particle generation, but then followed by a, quote, steady-state phase of decreased particle generation. Note that values greater than 7 parts per billion is generally an indication for advanced imaging with MRI. As far as invasive studies, the one to know is a hip aspiration, as a synovial fluid analysis will allow for differentiation of a metallosis from a periprosthetic infection. The gross appearance of metallosis is generally described as, quote, dishwater fluid with a watery, grayish, and hazy appearance. Finally, note that a manual cell count is necessary. This is because fibrinous debris from metal-on-metal reactions will falsely elevate automated cell counts. Moving on to treatment of a pseudotumor, this can be non-operative or operative. Non-operative management includes observation, which is indicated in the setting of a well-functioning total hip arthroplasty with low metal ions and no pseudotumor on MRI. As far as outcomes, studies showed that around 40% of patients with a pseudotumor are asymptomatic. Operative options include a revision total hip arthroplasty to a ceramic on polyethylene component. Indications include painful metal-on-metal total hip arthroplasty, elevated metal ions, and pseudotumor on MRI. Know that the rate of revision total hip arthroplasty due to symptomatic pseudotumor is only 1.7 to 5.6%. That being said, most patients with pain, elevated ions, or a pseudotumor on MRI require operative intervention. As far as outcomes, significant bone loss, soft tissue destruction, degree of abductor muscle deficiency, and a poor local environment for healing corresponds to difficulty of revision and functional outcomes. If patients have severely compromised abductor function or if their damaged soft tissue affects implant stability, these patients may require the use of a constrained liner. Also know that revision total hip arthroplasty for pseudotumor have higher rates of dislocation and infection. Now let's go over some of these management techniques in a bit more detail. As far as observation, in the asymptomatic patients, know that serial hip radiographs to assess for wear or component loosening can be performed. Moving on to revision total hip arthroplasty to a ceramic on polyethylene component, the approach depends on the location of the tumor and the surgeon's preference. A direct lateral and a direct anterior approach are commonly cited. As far as the technique, this can be a single stage or 2 stages depending on the surgeon's preference or presence/concern of infection. This can also depend on bone loss, abductor deficiency, and soft tissue damage. Finally, know that constrained liners may be required if there is severe abductor deficiency present. Complications include instability, deep infection, aseptic loosening, persistent iliopsoas tendinitis, and persistent metal-related reaction. Complications of total hip arthroplasty pseudotumor include repeat revision total hip arthroplasty and pseudotumor-induced femoral nerve palsy. Starting with repeat revision total hip arthroplasty, as far as incidence, know that 14 to 20% of revision total hip arthroplasties performed due to a metal-on-metal pseudotumor require a second operation within 5 years. The treatment involves revision total hip arthroplasty to address the reason for repeat failure. Finally, moving on to pseudotumor-induced femoral nerve palsy, the incidence is rare and only case reports are noted. Treatment includes decompression and revision total hip arthroplasty to ceramic on polyethylene components. Okay, so now that we've gone over the major points about this topic, let's go over a few questions to apply the information and get a sense of how this topic has been tested on past exams. The first question reads, a 45-year-old female is referred to you for evaluation of her right hip. 5 years ago, she was involved in a motor vehicle collision and sustained a femoral head fracture that was treated with a hip surface replacement arthroplasty. Her postoperative course was unremarkable, and she didn't have any issues until 4 months ago, when she noticed subtle hip and groin pain. She's otherwise healthy and wants to begin training for a marathon, but is concerned about her hip due to television ads about metal-on-metal devices. Her radiographs show a well-placed implant and are otherwise unremarkable. What test would be best to evaluate for the most concerning complication from this implant? And the choices are 1. CT including the pelvis, hip, and femur. 2. Whole-body triple-phase bone scan. 3. MRI with metal artifact reduction sequence. 4. Serum cobalt and chromium levels. And 5. Serum cobalt, chromium, molybdenum, and nickel levels. The correct answer to this question is 3. MRI with metal artifact reduction sequence. So this patient has a painful metal-on-metal hip, which requires a metal artifact reduction sequence, or a MARS MRI, to evaluate for pseudotumor formation and soft tissue destruction. To quickly review, metal-on-metal hip arthroplasties have become a burden for both surgeons and patients. As with traditional arthroplasty wear, which causes osteolysis, reaction to metal-on-metal debris also causes soft tissue destruction. In the setting of a painful metal-on-metal hip arthroplasty, infection and fracture should always be ruled out, followed by MRI to evaluate for soft tissue fluid collections or masses, termed pseudotumors. MARS MRI best correlates with prognosis in the setting of metal debris. Serum metal ion levels can be followed to monitor the amount of metal debris, but have little correlation with fluid collection or soft tissue destruction. Kwan discussed the use of MARS MRI in metal-on-metal hip arthroplasty. The MARS suppresses implant metal artifact to better define the soft tissues. Characteristic signs of metal-on-metal reaction are cysts and masses, collectively termed pseudotumors, tendon avulsions, and bone edema. New MRI protocols, for example Maverick and CMAC, have been developed since the adoption of MARS, but they compromise image quality and are difficult to use in preoperative planning. Kwan et al. Formed a consensus statement on the diagnostic approach to the patient with concern for metal debris from modular taper wear. They warn against relying on one clinical test when investigating the painful hip and emphasize the use of MARS MRI for detecting soft tissue lesions. Jacobs et al. Reviewed the utility of serum metal ion level monitoring. They note these levels can remain high up to 3 years following surgery, and there was little variation in total level amount between metal-on-metal total hip arthroplasties and resurfacing arthroplasties. Additionally, altered renal function can falsely elevate metal ion levels due to poor excretion. To quickly go over the incorrect answers, answer 1, CT is best used in the setting of periprosthetic bone loss. Answer 2, bone scans are nonspecific for many processes, including pseudotumor formation. And finally, answer 4, serum cobalt and chromium levels, and answer 5, serum cobalt, chromium, molybdenum, and nickel levels are incorrect, as metal ion levels may be used in surveillance for metal wear, but aren't useful in the setting of a painful prosthesis. And moving on to the final question, a metal-on-metal bearing used for total hip arthroplasty shows which of the following properties? And the choices are 1, baseline serum ion levels increase with increasing activity levels. 2, the risk of cancer is substantially increased. 3, linear ion production increases over time. 4, ions produced are excreted primarily through the kidney. And 5, nickel is the most prevalent ion released into circulation. The correct answer to this question is 4, ions produced are excreted primarily through the kidney. So activity levels do not affect cobalt and chromium ion levels, which are the bulk of serum ion levels. The majority of ions are produced in the run-in period in the first several years. A gradual reduction in ion levels occurs thereafter. The kidneys are responsible for the bulk of clearance from the serum, and to date there is no relationship of cancer to ion levels in the serum. That's all for this review about total hip arthroplasty pseudotumor or metal-on-metal reactions. Hopefully that was helpful. This is the OrthoBullets podcast, a daily audio review session by OrthoBullets, the free learning and collaboration community for orthopedic surgery education. Keep in mind that these podcasts are designed to go along with the topics on orthobullets.com, and in fact you can listen to these episodes right on the OrthoBullets website or mobile app while going through the topic. If you've gotten any value from the OrthoBullets podcast so far, please consider leaving us a 5-star rating and writing us a review on Apple Podcasts. It will help us spread the word and increase our discoverability tremendously. Thanks so much, and we'll see you all tomorrow.